look at the portosystemic portocaval anastomosis, the core idea is that the portal venous system drains blood from the GI tract, spleen, pancreas to the liver for processing. So we have a portal venous system, this blue system. Can you see this blue color? So basically, this drains blood from the GI tract, this entire GI tract, the spleen, and the pancreas, not shown here, and to the liver for all the processing. Now, uh, what happens is if portal pressure rises, classically from a condition like cirrhosis, what happens is that the blood backs up. When the blood backs up, it's diverted through pre existing connections between the portal veins and systemic veins, and it creates varices or collateral veins. Now, the main idea of this diagram is that the GIT through the portal vein, this is the portal vein, drains the portal system, the portal venous system into the liver sinusoids. In the liver sinusoids, it goes into the hepatic veins. These are the hepatic veins you can see. And then all of this goes into the inferior vena cava. Now, in cirrhosis, this resistance increases, and the blood seeks alternating routes via the portosystemic anastomosis. Right? Now, let's see where these anastomoses happen. We have four main anastomoses. The first one, three main sites of anastomosis. So, the first one is the esophagus, the second one is the umbilicus, and the third one is the rectum. Right? So, let's first look at the esophagus. Now, what happens at the esophagus level is that the lower esophagus has esophageal varices, right? What are esophageal varices? Basically, what happens is on the portal side, you have the left gastric vein. This is the left gastric vein. And on the systemic side, you have the esophageal veins. These are the esophageal veins that basically drain into the azygous vein, and the azygous vein drains into the superior vena cava. And what happens is that um, whenever you get portal hypertension, these dilated submucosal veins, basically cause esophageal varices. So, esophageal varices are abnormally dilated or tortuous veins in the submucosa of the lower esophagus. They are fragile and they're very prone to life threatening bleeding. They're not a primary esophageal disease, they're a complication of the portal hypertension. So, when portal hypertension develops, due to liver cirrhosis, which increases blood resistance through the liver. This can be due to cirrhosis, which is usually due to alcoholic diseases, viral hepatitis B or C, or portal vein thrombosis, or a Budd-Chiari syndrome, or schistosomiasis. So the blood looks for alternative pathways, and when the pressure rises in the portal venous system, the blood is directed or diverted to the systemic veins through portosystemic anastomosis. Now, one major site is the lower esophagus, and here on the portal side you have the left gastric vein, and on the systemic side you have these esophageal veins. The esophageal veins drain through the azygous vein into the superior vena cava. Because the esophageal submucosal veins are thin-walled and unsupported, they balloon out, right, under high pressure, and when they balloon out under high pressure, they cause varices. Um, Now, why are esophageal varices so dangerous? Because they're located in the submucosa, which has thin walls. There's no protective muscle layer. There's a constant trauma from swallowing, acid reflux, increased intra-abdominal pressure. So, a very high venous pressure here leads to sudden pressure spikes, and that leads to rupture. When they rupture, there's massive hematemesis, like bright red colored blood coming out, like in a vomit pattern. You get melena, hypotension. Apart from massive hematemesis, which is like bright red colored blood, you also get melena, you get hypotension, shock, and it's a very high mortality if untreated, because the bleeding is painless, sudden, and profuse. Now, why does this specifically happen in the lower esophagus? Because this is a junction zone where the portal venous drainage system meets the systemic venous drainage and makes a pressure release site in portal hypertension, right? Um, the next thing we should look at is our next system, which is the umbilicus area. So at the umbilicus area, you get something called caput medusae, right? These are like let me show it to you. So can you see the caput medusae here near the umbilicus? These are caput medusae, right? So around the umbilicus, what happens is you have the on the portal side, on the blue side, you have the paraumbilical veins, and the paraumbilical veins are actually supposed to be remnant of the ligamentum teres and the umbilical cord. But what happens is that due to an increased resistance and increased portal venous pressure, this becomes recanalized. Recanalized means it becomes, even though it's supposed to be solid, it's supposed to be like a remnant, it becomes hollow again because of that increased resistance in the portal venous system. On the systemic side, you have superficial epigastric veins. These superficial epigastric veins are present in the abdominal wall. So there is an anastomosis around this umbilicus through the paraumbilical vein and the epigastric veins. And on the systemic side, you have this superficial epigastric veins on the abdominal wall. On the portal side, you have the paraumbilical veins, and here you get something called these dilated veins around the umbilicus are basically called caput medusae. Why are they called caput medusae? Because they look similar to the caput. Caput is the head of the Latin god Medusa. So this is the head of the Latin god Medusa. So this is why they're called caput medusae, right? Now they're seen in portal hypertension, not usually life-threatening, but this is a big clue. You differentiate from inferior vena cava obstruction patterns. Whenever you have portal hypertension, the portal hypertension, you get radiating veins from umbilicus, but whenever you have inferior vena cava obstruction, you get prominent abdominal wall veins, but the flow pattern is different. Here you have an anastomosis between the paraumbilical veins and the epigastric veins. They are radiating veins from the umbilicus. The pattern is different when inferior vena cava obstruction is happening. The third area is our rectum anal canal area. Now, the rectum anal canal, from the portal side, it has the superior rectal vein. The superior rectal vein drains into the inferior mesenteric vein, and the inferior mesenteric vein goes on to drain into the portal vein. So the superior rectal vein is part of the portal system, and on the systemic side you have the middle and inferior rectal veins. The middle rectal vein, I told you, was a branch of the internal iliac artery, and the inferior rectal vein was a branch of the pudendal artery. So both of them basically drain into the inferior vena cava, right? So you get an anastomosis here also. So in the rectum or anal canal, you get something called as the anorectal varices. The anorectal varices are not like typical hemorrhoids. They can coexist, but they're not the same. Hemorrhoids are more related to local venous plexus issues like due to constipation, pregnancy, prolonged sitting, or straining, and their pain depends on the pectinate line. We'll see the pectinate line in the next section. And the portal hypertension creates dilated submucosal veins, which are higher up in the rectum and anal canal. But below the pectinate line, you get hemorrhoids, and usually above the pectinate line, you get anorectal varices. So these three things, these three umbilical areas get affected through the high resistance in the portal venous system. You get esophageal varices, caput medusa, and anorectal varices. Now there's something called as the TIPES, and this is the transjugular intrahepatic portosystemic shunt. What is basically this? It's a radiology procedure making a low resistance channel between the portal vein and the hepatic vein. So what you basically do is you create a bypass. Since in cirrhosis, what happens is the liver becomes fibrosed, it becomes like hardened, so there's a very high portal pressure. Now you need to drop that portal pressure by creating a bypass between the portal system and the systemic system. So what people do is they create a shunt here, this white colored shunt, can you see, between the hepatic vein and the portal vein. The shunt allows the pressure to drop, it drops the portal pressure, and this reduces variceal bleeding, ascites, but it also decreases liver filtering of toxins. So what happens is, when is the this shunt used? It's used when there's recurrent variceal bleeding or in refractory ascites cases. Major complications include hepatic encephalopathy. Why do you get hepatic encephalopathy? Because the ammonia and gut toxins are bypassing the hepatic metabolism. The fibrosed liver, it's bypassing it and it's reaching the brain. Now the ammonia rises. So the gut proteins, the ammonia produced by the gut proteins, produced by the bacteria of the gut proteins, does not get eliminated. Normally, the liver converts the ammonia into urea and detoxifies it. But after this shunt, more ammonia enters the systemic blood. It crosses the blood-brain barrier, and you get astrocyte swelling in the brain cells. This leads to confusion, asterexis, and coma in severe cases. Now, remember that there is something called as the pectinate line. This pectinate line is also known as the dentate line of the anal canal, right? So, why it matters is it helps to create the embryological border origin of the epithelium type innervation at blood lymph drainage. So, it's important to know where the pectinate line lies. This is the pectinate line. I told you above the pectinate lines, you get internal hemorrhoids or adenocarcinoma, and below the pectinate line we call it external hemorrhoids or an anal fissure or squamous cell carcinoma. Now the pectinate line is formed where the hind gut ends and the endoderm area ends, and it meets the ectoderm, which is also the proctodium. So let's look at this image clearly and carefully. Let's look at the pectinate line first, right? So here you have your pectinate line. Can you see this arrow? This is the pectinate line. It's a dentate pectinate line, right? So this is the anorectal line. This is where the anus ends and the rectum starts. This is the pectinate line. This is where the endoderm ends and ectoderm starts. And then this is the anocutaneous line. This is where the anal area ends and the cutaneous area starts. And this is also known as the sphincteric groove. And then this is the anal verge, the end, right? Now you have at the dental pectinate line, you have anal crypts, and inside this skin, inside the muscle part, inside the tissue part, you have anal glands. Now, let's look at the hemorrhoids here. So we have a set of muscles. We have this inner circular muscle layer. This is the inner circular muscle layer. Then we have the longitudinal muscle layer. This is the longitudinal muscle layer. And we have the levator ani muscles here. This is the levator ani muscle. This is the rectum mucosa. This is the external anal sphincter's deep part. This is the external anal sphincter's superficial part, and this is the external anal sphincter's subcutaneous part, right? Now look at the epithelium. This is important. Now the